Well, good evening and welcome to the Wolper Wellbeing Forum hosted by Wolper Jewish Hospital and Friends of Wolper. My name's Julie McCrossin. It's my pleasure to be your host this evening, and our topic is stroke awareness, prevention, management and rehabilitation. We're effectively going to try to share with you everything that you need to know about stroke. Let me begin by acknowledging that we're broadcasting to you on the land of the Gadigal people, predominantly based in Sydney, and to pay our respects to elders past, present and emerging. And if this is your first time with us, Wolper Jewish Hospital is a private hospital, a medical rehabilitation and palliative care hospital in the eastern suburbs of Sydney. Wolper welcomes people from all cultural and religious backgrounds while offering care within a framework of Jewish cultural, religious values and dietary requirements. And my own mother was a patient there for some time. We also want to acknowledge the generous donation of the Shell family in member of their husband and father, Dr. Alan Shell, OAM. Dr. Shell was a long-time supporter of Wolper Jewish Hospital, a passionate advocate of health education, and in keeping with his vision, Wolper will dedicate the family donation to ongoing community health initiatives, including these Wolper Wellbeing Forums. Now, just some quick housekeeping while some more people join us. Your questions are welcome throughout the webinar, and in fact, you can start putting them in the Q&A now. Remember, we can't see or hear you, so the Q&A is the only way for you to ask questions. And thank you to everyone who's sent questions in advance. Our question moderator this evening is General Practitioner Dr. Carmela Milka, and she will join me on screen with our panel members throughout the evening to bring your questions to our panel. We'll answer as many questions as possible, but of course we are unable to answer specific individual clinical questions. And this webinar is being recorded and will be available shortly on the Wolper Hospital website as a video recording, and it is also available as a podcast. And our community partner for this webinar is the Stroke Foundation. And it gives me great pleasure to welcome Professor Coralie English, who's a professor of physiotherapy at the University of Newcastle. And she's also on the board of the Stroke Foundation and the chair of the subcommittee for research. And she's going to tell us about the information and resources offered by the Stroke Foundation. Welcome, Professor English. Welcome.
Thank you, Julie. Did you want me to share screen now and start that?
That would be fantastic. Thank you.
Great. Ooh. Excellent. Thank you very much for that warm welcome, Julie. So I have got my Stroke Foundation hat on. I'll switch to my researcher hat later, and I just want to tell you a little bit about the Stroke Foundation and the support services they can provide. So Stroke Foundation is the largest NGO, or the trusted voice of stroke in Australia, and the lead NGO for stroke. A couple of facts here, and we'll return to them around the frequency of stroke in Australia. There's about 50,000 new strokes every year and about 500,000 people living with the effects of stroke in Australia. But the good news is that we'll come back to is more than 80% of strokes can be prevented. So very quickly speaking, broadly speaking, there's two main types of stroke. The most common one by far is a blood clot in the blood vessels to the brain, but that could also be caused by a bleed in the brain. The most important thing is that time is brain. And if you suspect that someone's having a stroke, it's a medical emergency, and the quicker you can get to hospital, the quicker you can get the life-saving treatments. And the acronym to remember is FAST, to any changes in face drooping, arm weakness, changes in speech, and remembering that T stands for time. So our Stroke Foundation strategy is around being stronger together, and we have 3 pillars around prevention of stroke, trying to reduce risk factors for stroke across Australians, saving lives through access to evidence-based care, and enhancing recovery and helping people live well with stroke in the community. two main resources I wanted to point you to, and we'll mention others through the evening. The main one is Stroke Line, which is manned by health professionals that provide information, advice, support, and referrals. So that's 9 to 5, Monday to Friday. And that's an excellent service for anyone who, people with a stroke, people with loved ones, support crew, and so on. We have a website that has as well professional staff or professional healthcare professional facing materials, but the one I wanted to highlight is focused on people living with stroke in the community and their support crew, and that's known as Enable Me. So that's a good one to have a look at. Loads and loads of resources for people living with stroke on that website. Thank you.
Look, thank you so much. It gives me great pleasure now to welcome our panel to the screen, and so we can welcome you all. Welcome to Professor Coralie English, Professor of Physiotherapy and Associate Dean of Research in the College of Health Medicine and Wellbeing at the University of Newcastle. Welcome to Coralie. Dr. Lauren Christie, an occupational therapist, a working clinician and researcher in stroke rehabilitation, and Senior Research Fellow, Allied Health at St Vincent's Health Network, Sydney. Welcome also to Dr. Tal Koren, a neurologist practising in East Sydney and Northern Sydney, and also at Wolper Jewish Hospital. And Tal has also clinical experience managing stroke in rural and regional New South Wales in Tamworth, Shellharbour and Port Macquarie. Welcome also to our special guest this evening, another neurologist and stroke specialist, Dr. Hamza Jubran, MD, from the Hadassah Medical Centre in Jerusalem. And we thank you immensely, Hamza, for overcoming time difficulties and differences. And Hamza has key interests, including stroke prevention and treatment and neurological rehabilitation. He also teaches and trains medical students and junior physicians, and he's published internationally in relation to stroke. Oh, now we're going to cover many issues, but if I could come to you first, Dr. Jubran in Jerusalem, tell us, what is a stroke? And tell us just a little bit more about the different kinds of stroke. We've had a little bit of reference to them there in our opening presentation. Welcome. If you could turn on your, thank you.
Hello, everybody. Thank you for inviting me. And what is stroke? Stroke is one of the leading causes for death and long-term morbidity and disability. And there are two types of stroke. This one of the types that occlusion of the blood flow to the tissue because of occlusion blocks of the blood vessel, and the other issue, the other type, which is less common if there is a bleeding in the brain. These are the two types of the stroke.
And what are the most common causes?
The most common cause for both types of stroke are the hypertension. The hypertension was the uncontrolled hypertension, and many people thought that they don't have any hypertension because they didn't check. This is what the important thing, that the hypertension is the silent killer. Nobody will feel that he has the hypertension, but if they will check and will monitor, they will find, and there is a need to be treated and to change the lifestyle accordingly.
And hypertension is high blood pressure.
High blood pressure.
Yes. And could I ask you, can you help us understand the importance of this idea that time is brain? If perhaps one of the most important things we can get across to people this evening is what a stroke looks like if you're with someone or if you're having one yourself. So what are the symptoms, and what is it important that we do as quickly as possible if we think we're having a stroke or someone we're with is having a stroke?
Okay, this is very important. The time is brain. We know all the body, and including the brain, are many cells that working together, one helping the other and working the function, moving the hand, speak, vision. All the cells that need the oxygen and the nutrition from the blood. And if there is an occlusion of the blood, that the blood is not coming to these cells, they will die, and they will die one after the other and within minutes. So because of that, the time is brain. Every minute, every second, we are losing, not making the blood again to these cells, they will die. And unfortunately, if the cells die, it will not it will be irreversible. That will not working again. And that's the important thing of the timing. As how the people will find that the neighbor, anybody beside them that have a stroke, whether it is the symptoms of stroke. So we'll do the fast. But I will add it on it, and this is another important, the P fast. What is the P? It is the balance. Like if the person have unsteady gait, dizziness, falling to one side, this is very important thing. And E, if there is any eye problem, that there is a loss of vision, there is a double of vision, this is another sign that it needs to take an action. And the F, it is the face. If there is a drooping of the face, as this is the third. If there is the first A, the arm or leg, any limb, that there is a weakness of the arm, that the things falling down from the hand. This is another important thing. S, if there is any abnormality in speech, slurred speech, or the difficulty to say the word. And T, the end, that if any of the symptoms happen, it is the time to call for help, to call the ambulance, and to go to the hospital.
Thank you. Could I invite Dr. Koren to join us on screen? Dr. Koren is the neurologist working in Eastern Sydney and Northern Sydney. I wonder if I could begin with you, Dr. Koren, and then come to Dr. Jubran. That critical issue of ringing 000, could you just emphasize again the importance of ringing the ambulance? Because I have heard of people hesitating, maybe getting someone to drive them to the hospital. Why is it critical to ring 000 and get an ambulance?
Yeah, absolutely. So as Dr. Jubran was saying, the critical point to get across is that every second, every minute that passes, your neurons are likely dying in the context of an occlusion of a vessel within the brain. So we really want to try to get patients to the hospital as soon as possible so we can offer them therapies. Within what we call the hyperacute stroke setting, so it's really within the first few hours of an acute stroke, there are particular therapies which we can offer patients. We speak about thrombolysis, which is a clot-busting medication. And the idea is we can try and give people who had a stroke a medication to break open the blocked artery, to try and release the damage and allow oxygen in blood to go back to those neurons which are not getting sufficient oxygen. But those medications are only really available and within the first 4.5 to 6 hours of an acute stroke. So the faster you get to the hospital, the faster you possibly can be a candidate for those therapies. We unfortunately, and I often get called on for strokes in the middle of the night. And when we see patients who come to the hospital after 24 hours, they've missed the boat to be able to get those therapies. So if you're worried about someone having a stroke, it's best to call an ambulance to get them to the hospital as soon as possible.
And Dr. Jubran, could you explain those treatments a little bit more? What actually happens for the patient when they arrive in the ambulance?
Okay, when the patient arrives for the ambulance, there is a need to the ambulance talk with the hospital, the nearest hospital, to tell them that there is a patient that has the symptoms of strokes, highly suspected for stroke. So the team, the neurological team, the stroke specialist, that needs to be in the hospital, in the emergency room, waiting for the patient to come and to make the things make more faster, to do the brain CT, brain imaging, to check if there is a hemorrhage, if there is a occlusion, and after that there is a need to decide if there is any option to treatment or not. And as we said before, the timing is very important, that there is a treatment that there is no way to give it after 4.5 hours, after 6 hours. And if the patient presented as soon, early after the symptoms happen, the they will receive the treatment, and also to open the vessel that is occluded, and the blood come to the cells, and the brain will gain the function.
And this word occlusion, can you just explain what that means? Occlusion.
Okay, that the occlusion of the vessel, why it happens? Because of the risk that the causes for the stroke. One of the causes that also we have to mention, the hyperlipidemia, the cholesterol, the high cholesterol. The high cholesterol will build up in the wall of the vessels, and 1 year after the another, it will occlude the vessel, and also there will be a plaque that there is cholesterol like a bump on the vessel that could move from the vessel from the neck to the brain, and also do the occlusion of the blood vessel. Another cause is also heart problem. If the patient has something like atrial fibrillation, that irregularity in the heart beat also will cause thrombosis, like the blood will be will clot, and the clots from the heart will go to the brain, and also make a blockage of one of the vessels in the brain. And like this, the cause happens, and all the medications, and now we could talk later on the treatment to open this vessel, that the blood will return back as soon as possible to the brain and to the cells.
And Dr. Koren, I still just like a definition of occlusion. I know we talk about clot busting treatments and retrieval of the clot. So is occlusion another word for thick blood clot? I'm sorry, I just want a definition.
Well, essentially it is. So if we think about vessels, so specifically an artery in that context, so if it gets blocked off, the same way as a water pipe may get blocked off by anything really, then no water is going to fly through the pipe. So the same as the arteries, if anything blocks them off, no blood is going to flow through them. So in our context, in the context of stroke, the majority of strokes are thinking about occlusion or a blockage based on lots of blood that basically got blocked off into a clump. So similar way that whenever you bleed, your blood eventually clots off. The blood itself, especially in the context of cholesterol clots, which can build up over time, can have a full occlusion of that artery.
And I know you've worked in regional New South Wales, and I've lived a lot and worked a lot in the country. This emphasis on speed, it must be an incredible challenge in rural and regional Australia, and in parts of Israel as well, Dr. Jubran. What do you do if you're in a regional area and it's hard to get that speed? Or we may not have people with the expertise in the hospital setting. Can you just tell us your experience in Australia, and then we might hear in Israel?
Sure. So I think in Australia, we have the difficulty of the tyranny of distance, where you can build very fancy hospitals throughout regional Australia. It's not always possible to get neurologists and stroke specialists in all those centers, and definitely not 24/7. So in practice, what happens is majority of tertiary hospitals will have at least a CT scanner. It will have an emergency department, whether it's Shellharbour, Dabo, Tamworth, anywhere, Broken Hill. But the people who staff those places don't specialize in managing a stroke. So first of all, we still emphasize for everyone to get to the nearest emergency department as soon as possible. And practically what happens then is that the local doctors would then call some of us stroke specialists within Sydney through a process called telestroke, where basically we get to assess the patient over a Zoom, over telehealth. We get the immediate access to the scans as they come out of the scanner. And even if it's 2 a.m, we guide through the local team about how to administer those clot-busting thrombolysis therapies. Now, some patients, and we can get into it as well if you like, could benefit from a process called clot retrieval. We can actually try and remove the clot out entirely.
Would you explain that? Yes.
Yes. So clot retrieval, again, only within the first 24 hours of a stroke. Same way that if you may have a blocked artery, someone may come in through the vein to try and remove a blocked artery in the heart. And for some people, if there's a very large clot which is accessible, we can get interventional neuroradiologists that will come in through your vein from your arm, travel up to the arteries in the brain, and will actually try and use a small hook to pull out that clot and release the artery. That's only really effective for very large blockages, but it's very useful therapy. But of course, we don't have those people everywhere around Australia. So the practicality of what happens is if you present with a stroke to Tamworth Hospital or Port Macquarie Hospital, we will call an air ambulance to transfer you, even in the middle of the night, to Sydney, to Prince of Wales, Royal North Shore, Royal Prince Alfred Hospital to get those clot retrieval therapies in a more tertiary centre.
Look, thank you. And how do you handle that urgency, Dr. Jubran, in Israel? Are you able to get people quickly to treatment? It's obviously a smaller nation.
Yes, it's smaller and it's more easy to the patients come to the hospital, and the time between to take to the hospital, it is shorter. And like in Jerusalem, we have two hospitals that they are giving the treatment for the clot retrieval, as Dr. Koren said. So they will come, and then the ambulance will talk with the hospital to make sure that everything is ready, and we are coming with the patient that we thought that he has stroke. The team will pick the patient from the ambulance and take them to the CT to do the CT to confirm that he has stroke, and going to the treatment through the medication through the IV line for clot removal, or to the catheterization, as Dr. Koren said, will go and remove the clot from the brain. So it is because of the smaller country, it is more feasible to come, and shorter time to come to these treatments.
Can I just ask you, Dr. Koren, if I could start with you, other than that immediate acute need, how long do people tend to stay in hospital after a stroke, and what other treatment before we're moving to the home-based and then other rehabilitation processes? So what else happens in the hospital?
So in Australia, we usually keep patients in the hospital after the immediate 24 hours for at least 3 to 5 days, depending on the severity of the stroke. There's a few different things that we focus on. So first of all, we're trying to work out what was the reason for the stroke. So as Dr. Jubran said, if someone has got an irregular heart rhythm, such as atrial fibrillation, and we try and detect it. So we put them on a Holter monitor to monitor the heart for 48 hours. We also monitor their blood pressure and their and a few other blood tests, just to make sure that it doesn't fluctuate too much. And we really want to make sure they don't get any complications in this immediate stroke settings. If you can imagine someone who had a stroke affecting their ability to swallow, they may actually develop aspiration pneumonia in that context. And we have to make sure that they're safe to eat and drink before we can even think about sending them home. So we're spending a lot of time on preventing complications, finding out the cause of the stroke. So irregular heart rhythm, we'll check the cholesterol, we'll check them for diabetes. If they're younger, we'll check for more irregular causes of strokes as well, if it's someone who's a young person presenting with a stroke. And then we actually start the rehabilitation process while the patient is in hospital. Because the earlier we start to get them to mobilize, to walk, and to speak, the better the outcomes they're going to have down the line.
And Dr. Jubran, is it essentially a multidisciplinary approach, because you're moving to preventing another stroke and to begin rehabilitation even in the hospital setting?
Of course, the treatment for the stroke and the detection of the stroke is multidisciplinary. The neurologist is one of the one part of this whole team. The radiologist who will detect the stroke in the CT, one of the team. Also, the cardiologist to work up for other issue in the heart that causes the stroke. They will need to also to help us in this. Also, the internist, the hematologist, what is the hematologist, the specialist in doing the workup for the blood coagulation, that there is a problem with the blood itself that causes the stroke. And also, of course, the rehabilitation and also the physiotherapist that will help the patient to improve and to gain their previous condition.
What I'd like to do now is to invite Dr. Carmela Milker, our general practitioner who's been monitoring your questions, to bring us some audience questions. And I may introduce our allied health team members as well as we answer the questions. Welcome to you, Dr. Milker. What sort of questions would you like to bring to us, please?
Thank you, Julie. We've had quite a few questions. The one that's come up is, what is the difference between a TIA and a stroke?
Okay. Dr. Koren, could you begin? What is the TIA? What does it stand for, and what is the difference?
So a TIA stands for transient ischemic attack. So essentially, it's the idea that someone develops acute neurological symptoms, whether it's difficulty speaking or loss of vision or weakness of one arm, but the symptoms themselves resolve within a few hours. And we use an arbitrary cutoff of 24 hours for that. The understanding of a TIA is that a patient had a blocked artery, again, similar to a normal stroke, but for whatever reason, that blockage was opened up by the body itself. And it hasn't caused any long-lasting damage. And if we scan the patient, either with a CT or an MRI, we actually can't see any evidence of an ongoing blockage. But there are particular symptoms which would suggest to us that this is very much in keeping with a blocked artery which opened up after a time in the TIA. So classically, it's an acute onset of symptoms. Typical ones people describe being loss of vision over one eye, which slowly comes down as a curtain for an hour and disappears. And in those contexts, we get quite concerned because it suggests to us that someone has essentially had a small stroke which resolved, but is then increased risk of getting further strokes down the line. So we still treat them in a very similar manner in terms of trying to assess the blood pressure and cholesterol, check it for diabetes, and really try and do the best we can to avoid them having any future strokes in the future.
You can really see that having an active relationship with your general practitioner, checking all these causal elements that can lead to a stroke, is absolutely critical for both prevention but also recovery and prevention of a second stroke.
Yeah, absolutely. And we often communicate with the GPs on quite a regular basis in terms of, we tell the patients, when you go home, you still have to go to the GP because someone needs to check your blood pressure when you go home. Someone needs to make sure your cholesterol is actually coming down if you're giving your cholesterol medications. And even the lifestyle factors such as alcohol, reducing smoking, regular exercises. It's important to make sure that you have someone who is aware of different approaches to managing those to reduce those other risk factors from the lifestyle as well.
Look, thank you. Another question, Carmela.
Thank you. Which is the best hospital in Sydney to attend to if somebody is having a stroke?
And could I ask for Dr. Jubran to be on the screen as well, because some of the questions I can come to both of you. Tal, that's quite an interesting question. How will you answer that?
Look, I think all the hospitals in Sydney are pretty good. I've myself worked within the stroke service in both Prince of Wales, Royal North Shore and Royal Prince Alfred Hospital, so I could predominantly speak about those ones. They all have excellent stroke teams, and they all have dedicated stroke neurologists, stroke nurse practitioners, and an allied health team which specializes in stroke. What actually happens in the real life is that when you go into an ambulance, and again, the focus is go to the ambulance, don't go to the emergency department yourself, they will call the hospital in advance and see whether they have the space available to facilitate whatever treatments you think they need. And they may actually reroute you to a more appropriate hospital depending on how far the stroke ward is and whether or not, if you need, for example, a procedure like clot retrieval, where they'll actually be able to provide it to you that night. And we often send patients between different hospitals in the middle of the night, depending on what is available.
And presumably, if you were in some other hospitals, even within the Sydney metropolitan area or the Melbourne metropolitan area, we may have Melbourne people watching, you may move people to specialist hospitals in certain circumstances?
Yes, yeah. So the best example I can think of is in the North Shore. So if you present with a stroke to Manly Northern Beaches Hospital, to Gosford or to Hornsby Hospital, the ambulance will actually take you straight from there to Royal North Shore Hospital because that's the the main stroke center. If that makes sense. But
And,
we all work within the same network.
and what's the situation in Israel, Dr. Jubran? Because I'm very aware there could well be people watching who have family in Israel. I know there are. So do you have that specialist option available readily for all? In terms of rapid access to treatment, are there a number of hospitals who can provide that within Israel?
As I said, because of the smaller country, there is like a percentage. It is more than what Dr. Koren said, and also the awareness of the people is how much they call the ambulance, and we keep saying that there is a need to call the ambulance, not to come alone to the emergency room, because as I said, when they come with the ambulance will talk with the hospital, and then the doctor, and also all the teams will waiting for them. But if the patient came alone to the emergency room, it will take a long time to come to the emergency room. And the team will notice that the patient has stroke just when he's received in the emergency room and in the triage. So it will take time. So we are keeping for awareness for this rapid coming to the emergency room, but also what is still not very covered, the risk factors, the hypertension, diabetes, smoking, and also the lifestyle that is still not controlling it very good.
That's why you're so passionate about public education and motivated enough to join us tonight, which we're grateful for. Yes. Yeah. Let's have another question, Dr. Milker, before I introduce our other panel members.
So I think this is a good question for the other panel members. It's a great question. It says, what is the current evidence for intensive allied health intervention, specifically speech pathology, physiotherapy, and occupational therapy for people who've had strokes?
Look, thank you. If I could have Professor English and Dr. Christie on the screen at the same time. Can I come to our physiotherapist first? Coralie, how would you respond to that?
So thank you. We have got good evidence that more therapy, and particularly more therapy early, is better. Our clinical guidelines are excellent in the world, and I say that having helped to pull them together years ago. But what we have in Australia is these living clinical guidelines, which means they're the only living clinical guideline for stroke in the world. They're accessible internationally, but it means as soon as there's new evidence from research, it gets updated. And so people like Dr. Tal and Dr. Hamza can look up online at any time and see, oh, now actually it's safe to do the treatments for a longer period of time, or now we know that this sort of therapy is really effective. In terms of the intensity, as an example of that, there was a really large international trial that I was involved with that's just been published only a few months ago that has told us more information about the optimal timing and amount of therapy early after stroke, and particularly the physiotherapy, getting people out of bed. So we now know that we don't want to get people up before 24 hours. They do need some time for their brain to recover, but then as soon after 24 hours as possible. And we've got really detailed data now about how often and for how long people should be getting up and out of bed to get moving. But the shorter answer to your question is more is better, and more short bursts frequently in the earlier stage is better. And we do know that people aren't getting enough of what they need. And Lauren's done some fantastic work in terms of intensity of therapy, particularly for arm recovery, that I'm sure she can tell you about.
Yes, can we hear from our occupational therapist, clinician and researcher, Lauren?
Thanks so much, Julie, and thank you, Coralie. As Professor English has outlined, we now have some really clear information about how we should manage rehabilitation in those early stages after stroke. Once people are medically stable, we now then know people then need to be doing as much as possible, really, in terms of scheduled therapy. And that's across disciplines, across physiotherapy, occupational therapy, engaging people in lots of their day-to-day activities, upper limb rehabilitation, for example, as well as in the area of speech therapy and communication and swallowing. What we also know, though, is that in terms of how our services are currently staffed, is that we're not going to be able to provide enough practice, as Coralie says, if we focus on just seeing people one-on-one. Unfortunately, our staffing ratios just mean that one-on-one session with each patient each day is not going to be enough practice. So we do have recommendations within our guidelines as well to teach people how to practice on their own, either with the support of family members or using other independent practice strategies to help people to be getting in as much practice as possible.
So there's this issue of needing the right rehabilitation and the right amount frequently enough to get maximum recovery. And is that capacity for recovery, does that, Lauren, differ from person to person? Is it a very personalised thing?
Yes, it is, Julie, and I think that's where it one of the challenges is for us within stroke rehabilitation and stroke more broadly is that the symptoms that people experience after stroke can be very varied. The severity of the stroke can be quite varied, and so then we really do need to think about how we tailor that rehabilitation to best suit the needs of that person. As Coralie said, for some people that's going to be frequent, shorter bursts of therapy throughout the day, whereas there might be other people who can engage in therapy for longer blocks of time. So that importance of tailoring of therapy to people's individual needs is a real area where we're continuing to learn more.
And Lauren, could you just summarise the key most common side effects of stroke?
Yes, so in terms of from a rehabilitation perspective, the key areas that we often see people presenting with are what we'd refer to as motor problems, so weakness in their leg or their arm that then impacts on areas such as walking, balance, and their ability to use their arm in day-to-day function. People might also experience changes in their what we refer to as cognition, so their thinking skills, their memory, attention, ability to process information and problem solve. It's very common that there might be changes in their speech, their communication, either understanding of information or their ability to communicate to others. Their swallowing can be impaired, as Dr. Koren has already explained, so that then places them at increased risk of complications like aspiration pneumonia. People may also experience changes in their vision. So visual field loss, which can then have implications for their ability to be able to get around safely or return to activities like driving, and what we also refer to as perceptual problems. So their ability to understand where their body is in space and also in relation to other objects and how to use those objects. There's some of the key areas that we see within rehabilitation. In addition to that, we also see for some people there can be changes in mood. So anxiety and depression can be quite common after stroke, as well as changes in energy levels, so changes in fatigue, which Professor English is an expert in that field. So there's some of the main areas where we can see changes, and obviously that has a significant impact then on people's ability to engage in roles and activities that are meaningful and important to them.
If I come to you, Coralie English, our physiotherapist and researcher, I like to offer hope to people, and we've got quite a lot of people listening, watching us tonight who've had a stroke or have someone close to them who's had a stroke. So what is the perhaps the first thing I guess I'd like to ask you is to just tell us more about those resources that are provided by the Stroke Foundation, because information helps us know what to ask for, if I could put it that way. And you've been very involved in the development of the website materials and is it the iRebound website, which I was having a look at. And I'll get you to outline the content there and how that people can find it. But I was so impressed that there were many people who've had stroke demonstrating and communicating practical tips and ways to regain capacity to live their lives. Can you explain what's available there on that website?
Absolutely. And before I do, in terms of your comment about hope, Julie, the important thing is that the most rapid recovery does happen early after stroke as the blood flow is going back and as the brain can remold. But recovery can continue for people throughout their entire life. So continuing on with rehab, continuing with practicing what you want to be able to do, that you can always continue to improve. And Lauren and I both do a lot of work with people who've had a stroke in our research, and those people tell us all the time about the new recovery they've made and how they can improve. So it's a lifelong journey. But coming to iRebound, yes, that was a particular baby of mine and my team. This was something that I did in conjunction with the Stroke Foundation, a PhD student and a group of other researchers, but most importantly, a group of people who've had a stroke. We refer to them as our lived experience research partners. And we had this idea that we wanted to create accessible resources for people to be able to live well after stroke, with a particular focus on secondary prevention, so particular focus on helping people be active and eating well, but also, well, that was what we started with. And the whole section that's actually most popular on that website now is the hints and hacks, which our lived experience partners said, we want a section on hints and hacks. We want it to have almost no health professionals on there. You'll see there's a bit of a talking heads piece from me and a couple of others, but all of the videos are our volunteer and our research partners. They want it to be strengths-based and positive. This is what you can do, not deficit-based. And before that website existed, when I was thinking about and pulling it together with the team, to look up exercises after stroke or tips for eating after stroke, you'll get very websites with very clinically, what obviously looks like a physio in a fake lounge room saying, do this exercise, lift your arm like this. And we wanted to create something that showed people they could relate to and show people what they could do. So we're very proud of that website. What we would love is to be able to update it, put on fresh material, and adapt it to be more culturally responsive and appropriate as well. It is quite limited at the moment, and we haven't been able to refresh it through because we haven't had the funding and resources. So that's our hope for the future.
And Lauren mentioned you've done work on fatigue and helping people fatigue. And I think a very large number of our audience have indicated fatigue. Could you just speak to that? What can help with that?
Yeah, look, it's I did notice that, absolutely. And we know that for people who've had a stroke, it's most people the stats tell us at least half, but I've met very few, a handful, but very few people who have survived a stroke who don't have fatigue as a major issue. And we don't have yet evidence-based treatments. My team is working on one that's got some promising results. In early studies, there is some promising results about a particular medication that might help. But for many people, it's the most debilitating aspect of their life after stroke is this fatigue that is absolutely overwhelming and means that they can't function the way that they want to. We've also just done a piece of work around Australia in combination with the Stroke Foundation researchers, but again, very much in partnership with an engaged group of people who'd had a stroke. We've set research priorities. We've looked at the evidence gaps. We've looked at then the preferences of people living with stroke and health professionals. And what came out of that in the area of rehabilitation and life after stroke was understanding the causes and developing treatments for fatigue is the number one research priority that we need to be focusing on.
Just before I come to my neurologist and then to our audience questions, I just wanted to ask about equity of access, Lauren, Christie, because I know you feel strongly about that. If I could just quickly say, I had throat cancer, was treated with radiation, and I lost speech completely for 6 months and most of my capacity to swallow for a good part of a year. And I have to be honest with you, my capacity to purchase private allied health support and have a lot more contact with the speech pathologist in particular was critical in my recovery. So is equity of access to that intensity of ongoing allied healthcare an issue?
Yes, it is, unfortunately, Julie, nationwide. So, and it's felt even more prominently by stroke survivors living in our regional and remote areas of Australia. Um, to share with the audience, though, we are doing some work around this. I'm part of a national rehabilitation task force, and that is one of the areas that we are investigating, is looking at ways in which we can improve equity of access to rehabilitation. As Dr. Koren mentioned, our length of stay after a stroke now is relatively short. People might only be in for, say, roughly 5 days, and then that's followed by rehabilitation either as an inpatient or an outpatient. With those changes, it's really, we're starting to look more specifically, both in research that I'm leading as well as research Professor English is leading, looking at how we can also be using telehealth and virtual models of care to address this issue of equity of access to rehabilitation, because that has benefits not only for stroke survivors in regional and remote areas, but also for those in metro areas where it's difficult to be getting into a hospital 5 days a week for intensive
Because
therapy.
not everybody's got someone to drive them.
That's exactly right. That's exactly right. So there is work being done in that space to help try and address some of that. And I'm hoping that within, the next decade, we're going to see much greater access to that, using virtual care and telehealth models to improve that equity of access to rehab.
I know we commonly talk about this 10-year gap with research, but I think COVID taught us that when the pressure's on, we can move faster. So no, not 10 years,
No.
2 years. I want to
Yes.
set a different goal. Could I come to Dr. Koren and Dr. Jubran, if you could join me? I just want to hear a little bit more about the role of the doctors in the hospital, well, doctors in general, in the rehab after people leave the hospital, after that acute period. Obviously, allied health is critical, but do doctors still play a role in that ongoing rehab? And if so, what? Is it mainly general practice or is it specialists as well? Dr. Koren, do you want to kick off with Australia? If you turn your microphone on, please.
Sure, there you go. I think that's why I reflect everything that Dr. Lauren and Professor Coralie said as well. Like the rehabilitation does happen for for months, sometimes years after the initial stroke effect. And it's actually quite rewarding to be working in stroke clinics where we see patients as they leave the hospital and then 3 months after they come back. And to see that difference in terms of what they're able to do even just 3 months later is quite a rewarding experience for myself. What we want to do with patients is we make sure that all the investigations for the cause of the stroke were addressed. So sometimes, especially if the hospital is full, if people want to go home, some investigations may be missed, like an ultrasound of the heart or adequate investigations of the heart rhythm. And especially for patients that we are quite suspicious that they may have an irregular heart rhythm causing clots to travel from the heart to the brain, we actually provide them with wearable devices, which they can wear for weeks on to try and assess for irregular rhythms, which may only come on every few weeks, but can still cause damage. We make sure that they're actually taking the medications. And unfortunately, lots of people, once they leave the hospital, they think that they may not need the medications anymore. So it's important to us to educate them the role of the medications and how they need to keep using them, depending on the specific settings. But also we do assess quite routinely for the other complications of stroke that Professor Coralie spoke about. So mood is a big problem. And we know that stroke can cause depression in some people in terms of the actual effect on the neurobiology of the brain. And we sometimes need to treat patients even with medications together with psychotherapy to address issues like depression and fatigue and anxiety to assess them in the rehabilitation process. And as, of course, fatigue is a very common problem across all neurological conditions. We see it in multiple sclerosis, we see it in myasthenia gravis. And we try and make sure there's nothing else contributing to that fatigue and that loss of brain reserve, which we can address. So we check them for anemia, we check them for iron deficiency, we check them for thyroid problems, we check them for sleep apnea. And there's lots of things that you can try and assess which may be contributing to fatigue. But I agree, unfortunately, the medications that we have for fatigue are quite limited at the moment. So if you can find more research in that area, it will be a very, very welcome advancement.
Could I ask Dr. Jubran to join us as well? And I wonder if you could share with us your observations about rehabilitation and systems that are effective in assisting the allied health team, that interrelationship between doctor and allied health, please.
Of course, that the rehabilitation team, also the doctors that here in Israel, also there is a specialist in rehabilitation, that neurologist specialist in rehabilitation, that will check the situation from the neurological wise, why the patient has the symptoms, why the patient has the stroke, and will continue also the evaluation for the stroke, why the patient has the stroke, to address the cause, and also to work on the rehabilitation on the multidisciplinary issue, the mood, diet. Also, the diet is very important in rehabilitation, and also the physiotherapy, the occupation, how we can help the patient to go back home with nearly the same baseline situation. And as Dr. Koren said, when we are seeing like doctors, when we are seeing the patient in the emergency room in the first few days after the stroke, and see the patient after 3 months, 6 months in the clinic, there will be a huge improvement in this situation. And also the patient have to make the steps to do the strength to come back and to make a follow-up to prevent the other stroke and to control all the things that we already said. And also the primary physicians, not the neurologists and not in the hospital, in the family doctors, there needs to address these issues to follow up for the hypertension, the dyslipidemia, the high cholesterol every 6 months, that not to miss a patient that had the stroke and still he didn't control these risk factors to prevent another stroke. And one thing I want to mention that we didn't mention before, that we are talking about stroke in the elderly, but it is not affecting just the older patient, not the elderly. It also may affect the younger patients. Many patients also during the adulthood and also in their 30s will experience a stroke, maybe because of a heart problem, and also we don't want to forget the smoking and also the drug abuse. It is one of the things that may cause stroke at a young age.
And it has been indicated to me that there is an increase in younger people having strokes. Is that correct?
Yes, because of the sedentary lifestyle now, and also the diet that many people now taking, it will affect the vessels earlier than elderly. And because of that, we are seeing the increase in the population, the younger population with stroke.
And when you emphasize the importance of diet, are you referring there to weight loss in particular as a good thing to aim for as a stroke prevention or second stroke prevention?
About the diet, we are talking the Mediterranean diet, that fruits, vegetables, we avoid the saturated fat, the processed food. These things to prevent and to make the fish, for example, one of the things that will give the Mediterranean diet and will improve the health, and also will decrease the weight, and decreasing the weight will also prevent the stroke, and also the sport and exercise. This is the home message: to do sport, to exercise, not to be athletes, just to do a sport like a quick walking for 30 minutes a day, every day, will prevent the stroke.
And how common is a second stroke once you've had a stroke?
It is, if we are talking about the duration, as the duration is early, if we are talking about stroke, the duration in the first month, it will be more risky to have a stroke, especially if we didn't address the cause for the stroke. For example, if the patient has a heart problem and the patient didn't do the Holter, the monitor for the heart to check if there is a irregular heartbeat, it will recur. And
Okay.
if there is a patient with hypertension that didn't control it, it will recur. And the recurrence of the stroke is mainly within the first few months after the first stroke or the first TIA, the transient ischemic attack.
Okay, look, thank you. Let's come to our audience questions now, and welcome back to Carmela, Dr. Carmela Milka, with questions from the audience. Thank you.
Thanks, Julie. Another question is antiphospholipid syndrome and factor V Leiden. How is that related to stroke?
Could I come to Dr. Koren, if you could explain what those references were to, and if there's a stroke connection, please?
Yes, sure. So when we think about people presenting to the hospital with a stroke, it's usually in the Australian setting people of older age, so people in their 70s or in their 80s who over the years have accumulated those other risk factors that we spoke about before. So high blood pressure, high cholesterol, diabetes, smoking, alcohol. But we do see patients who are young who present to the hospital sometimes, as Dr. Jubran alluded to. So that's people in their 20s, 30s, and 40s. And if there's no history of drug abuse, for example, then we try and look for the more rare causes of stroke, which may predispose a young person to have a stroke at a young age. So some of them are autoimmune conditions, such as antiphospholipid syndrome. That's a particular condition which is somewhat associated with lupus, whereby the body is more likely to form clots, and those may appear in your legs, like a deep vein thrombosis, a DVT in your lungs, but it can also travel to the brain and cause strokes. Factor V Leiden deficiency is it's a genetically inherited condition whereby the body is missing a particular factor within the coagulation process in the bloodstream, which means, and again, you'll be more likely to form clots. We often, especially in young women who have strokes, they may give us a history that they've had a history of significant miscarriages in the past, which again increases our suspicion for those conditions. What we do these days is if someone is coming at a young age with a stroke, we actually don't only test for those conditions individually, we actually do them as part of a panel. So we test for over 10 or 20 different inherited conditions which may cause a stroke. We do different blood tests to check for autoimmune causes of stroke. And we also check for more structural abnormalities of the heart, as Dr. Jubran alluded to as well.
Wow, I'm really learning. One thing I'm taking away is the critical aspect of assessing the cause so that you can address the cause of stroke. That's coming through loud and clear. Another question, Carmela, please.
Yes. Are there any alternatives to taking statins to reduce cholesterol?
Dr. Jubran, would you answer that one, please?
Yes, actually, the statins is the medication that reduces the cholesterol, the cholesterol, the LDL. It is one of the cholesterol is many types like LDL, HDL, triglyceride. LDL is the major cause for changes in the blood vessels. And other than statins, there is new medications add on statins, not instead of statins, like ezetimibe, one of the medication that will help the statins. And there is a new era of anti-PCSK9 inhibitors. That these medications, IV injections, meanwhile, that patients who had allergy to statins, or there is a side effects of statins that may cause a muscle pain, very fatigue and muscle pain. So there is an alternative of giving them the anti-PCSK9. It is injections once every, this is changes according to which medication. But yes, there is an option to switch to another treatment. But if there is a side effects, if there is side effects or there is no response.
Okay, thank you. Did you want to comment, Dr. Koren?
I agree with what Dr. Jubran said. I think it's important to emphasize that while in the general population we speak about reducing cholesterol because it's good for vast different things, it's good with your heart disease together with brain disease, and we often advocate for, in the general population, for dietary changes first, and specifically Mediterranean diet, low animal fat diet. In the context of people who've had a stroke, we put them in a different risk profile. So the idea is those people are an increased risk of having further strokes in the future, which is why we think there's benefit for starting cholesterol medications such as statins. And it's particular for those patients. The benefit significantly outweighs the possible complications of the medication.
Look, thank you. I'd like to do just keep moving through audience questions so we can answer as many as possible. So another one. Thank you, Carmela.
Another one. Any tips for assisting with dysphagia, which is problems with swallowing?
Could I come to Lauren Christie first? Yes, what
Thanks,
would be
Julie.
your tips with can you explain dysphagia and then what helps? Yes.
Yes, so it was dysphagia with a G, Dr. Carmela, just to confirm.
Yes.
Okay,
yes.
So that's an issue with swallowing function after stroke. And what can happen is that, and again, I'm not a speech pathologist, so I hope I don't overstep my professional mark here. But basically, the way in which when we swallow, we get things that close off to prevent food from going down into our lungs, that doesn't happen as effectively. There can also be changes in terms of the coordination of the muscles within the face and the throat that help assist with swallowing function. And so I think from that regard, the best thing to do is to speak to a speech pathologist. You really need to look at having specialist expertise around swallowing rehabilitation. It is an area that needs some further research, support for research, because it's so critical to improving people's quality of life and being able to return to eating, food and fluids. So I apologize that I don't have an easy answer for that, but it is a specialist area, and I would seek the advice of a speech pathologist with experience in stroke.
Thank you very much. And Coralie English, did you want to comment on that?
No, just to say in terms of what people can do to manage that, again, under the advice of a speech pathologist, but you can alter the texture of your diet, looking for soft foods. We used to do, we still do some in the hospitals, use of thickened fluids. If people have lots of problems swallowing and are at risk of liquids going into their lungs, then sometimes we have to put thickener in people's drinks, which is not very pleasant at all. If you can imagine never being able to have a cool drink of water, you just have to glug down like gluey stuff. What research has shown us over the last, or Lauren might have to correct me, 5, 6, 7 years, is that with just water, the risk of getting pneumonia if you accidentally get some pure water in your lungs isn't too much. And so we do in hospital, it's now recommended, unless people have got very severe swallowing issues, that they can sip at least water. But I think, as Lauren said, it's about the advice of a speech pathologist. But if people are having difficulty swallowing and chewing, it is about softer foods, slowing down, eating while you're sitting up, and being careful and taking it seriously, because you can, of course, choke, or if you get food and the wrong sorts of liquid in your lung, you can end up with a pneumonia, which can be very serious.
Yes, I've been hospitalised twice for what they call aspirational pneumonia because of swallowing difficulties. Because basically there's 2 pipes and it goes down the wrong pipe. So speech pathologists are crucial, and there is private speech pathology again, and that's an equity of access issue. Would either of the doctors like to comment on that? Because the impact on speech and swallowing are 2 hugely significant things for people. If you wave, if you'd like to join us, but if you're happy with our response so far, it looks like you're happy with the allied health. Let's have another question, please.
Why do stroke patients experience pain in the affected areas after a stroke?
Dr. Jubran, would you like to come in?
Okay, there is, according to that type of stroke and the place where the occlusion of the blockage of the vessel, there is one area of the brain that calling thalamus. The thalamus of the brain, if there is a stroke in the thalamus, the blood not coming enough to this area, and it will die. This will cause the numbness, like tingling, and feeling sharp sensation in the limbs, and after that they may cause pain. Like instead of loss of function, there is an increase in the function that in the abnormal sensation.
And Coralie English, your thoughts?
Yeah, I just thought I would add as well that those those can be causes of pain being created, the sensation of pain being created by the brain for no reason, so to speak. But the other causes for pain can sometimes be related to the motor function, the weakness, and so on that someone's suffering. And shoulder pain is really common because if you've got complete paralysis of your shoulder, you can get or subluxation, so some separating of the joint. And if you've got weak muscles around your shoulder, the muscles that are trying to work aren't working in the right way. So it means your bones can be jamming together. If you haven't got good stability around your hips and your knees, then you can cause pain. So that can be another cause, and that's where physiotherapists can be and occupational therapists very helpful in ways to manage that as well.
Lauren, Christie, you're nodding madly, our occupational therapist. Would you like to comment on that? And I think you've done work with something called constraint-induced movement therapy that is about upper body strength. I don't know if this is an opportunity to mention that.
Sure. So constraint-induced movement therapy is one of our evidence-based interventions. It's recommended in the stroke guidelines. It's got really high quality evidence to show it can improve function after stroke for those with more mild to moderate weakness in their arm after a stroke. So it's a really great intervention, a boot camp style intervention that can help people to regain function within their affected arm after a stroke. I was just nodding madly to what Professor English was saying in relation to some of the changes and pain that people can experience and the reasons for those after stroke. We know that there's also a correlation between people experiencing shoulder pain and weakness in specific muscles within the shoulder joint. So where we know that if part of their rehabilitation is focused on training and trying to improve how much strength people have within those muscles, that can also sometimes help to reduce the amount of pain that they experience.
And pain relief, tell Koren, is that a part of follow-up? Is that left to the general practitioner, or in your 3 or 6 monthly checkups? Is pain management part of what you do?
So we absolutely do ask questions about pain. There are particular medications which you can use for neuropathic pain, like the types that Dr. Jubran discussed. And we do use those ones. We try to avoid using opioid-based medications or anything addictive. The only thing I would also mention, to add on to what Lauren and Professor Coralie said, while a lot of patients initially after a stroke have weakness of the arm or the leg, if you see them a few months down the track, they actually develop spasticity, which is a rigidity of the arm or the leg. And that it basically the brain normally tries to dial down the movements of the muscle. When that pathway gets injured, the muscles stiffen up. So while they may have difficulty doing movements, a lot of it is actually to do with spasticity and rigidity of the arm or the leg. And it by itself can be quite a painful process as well. So we try and use different techniques to try and reduce the spasticity, either through physiotherapy, and there's a lot of good evidence behind on physiotherapy-based activities for that. But sometimes we have to use medications to try and reduce the spasticity and the rigidity, both to reduce pain, but also to enable function of the arm or the leg.
And does massage have a role there?
It does, absolutely. And there's a whole list of different adult health-based therapies which can be assistful for managing spasticity, absolutely.
Coralie English, would you like to comment on that issue of spasticity?
Yes, it is. It is a big one. And yes, massage, stretching can give some temporary relief. But what we do know now is that there's good evidence that intensive stretching does nothing to actually reducing spasticity. There used to be a school of thought that putting splints on, spending a lot of time with a therapist doing stretching regimes would help reduce spasticity. And now evidence of what doesn't work is just as important as evidence of things that do work. And we now know for sure that intensive stretching does not change spasticity. But the therapies through an expert who can look at where the muscles have the spasticity and what muscles might be able to be trained up to help counterbalance that is really important. and being assessed by somebody for that. But also there's the medication called Botox, which most people associate with wrinkles and crow's feet, has really good evidence for reducing spasticity in people, and it's particularly useful if the spasticity is painful, if it's limiting someone's function. And if it's limiting, there are some people who have very severe spasticity, so their fist will be very tight and they can't open it up. And being able to release that with Botox, and that's the only time really that we think about putting splints on people, just so that they're not damaging the skin so much and then getting skin infections and skin hygiene and so on.
I'm just thinking, several of you have mentioned the state-of-the-art clinical guidelines that are updated, I think, every 6 months and are publicly available. What would you Google to find them? Because highly motivated family members or people who've had stroke might like to look at the latest research so they can talk to their doctors about it.
Very easy. If you just Google stroke guidelines, you'll find them. But they are housed on the Stroke Foundation website, so you can navigate to them that way. But if you add in living stroke guidelines and Australian stroke guidelines, you will find them very quickly, and they're freely available. Yep.
Let's see if we can do 2 or 3 more questions. I'll come back to you, Camilla Milka.
Yes. Does being a migraine sufferer predispose to having a stroke?
Dr. Jubran?
If migraine?
Yes.
Migraine.
Okay. There is a link between migraine and stroke, absolutely. But the migraine with aura, what is the aura? There is a symptoms before the headache. What is the migraine? It's a headache, one type of the headache, the primary headaches. And the aura, it is could be visual aura, the visual symptoms, or sensory symptoms, or weakness before the headache. And they notice in the researches and the previous researches and papers that women with migraine with aura who are smoker and also taking oral contraceptives, there will be a very increased risk of stroke, especially at a young age.
And is there anything you can...
If the patient has a migraine with aura, we advise her not, of course, not to smoke, and also to be sure that the oral contraceptives not containing the estrogen, that it cause increased risk of stroke.
And is there anything else you can do if you have those migraines to reduce your risk of stroke?
Just to prevent the other modifiable risk factors.
Okay, thank you. Another question, please.
Is a stroke of the eye the same, and is the treatment the same?
Dr. Koren?
Yes, sure. So depends what they mean by stroke of the eye. So you can have an occlusion of the ophthalmic artery, which is the artery which branches off to give blood to the entire eye. And it traditionally presents with a kind of loss of vision of the whole eye in one go. And those ones we do treat as per a normal stroke, especially in terms of the preventative therapies. You can get strokes of the very small arteries within the eye and the retina, which can also cause loss of vision. Unfortunately, for those ones, there isn't as good evidence to suggest that the hyperacute therapies that Dr. Jubran and I spoke about are beneficial. So we don't use them as often for those kind of form of strokes. But we still speak about the same long-term management because the same people who developed stroke affecting vision can still get more strokes down the line. So we still speak about the exact same modifiable risk factors of cholesterol, diabetes, hypertension. We still give those patients aspirin long-term to reduce the risk of having further strokes down the line.
Dr. Jubran, would you like to offer further comment?
Yes, actually, as stroke in the eye, if there is the stroke, the large artery, it's a smaller artery, but the largest in the eye, the ophthalmic artery. Actually, I had 2 researches about this issue, the central retinal artery occlusion, and we see that there may be a benefit from the same management with the thrombolysis, the clot resolval. But still, this is under research. But what is important to control the risk factors, because the risk factors for the stroke in the eye and the stroke in the brain, it is the same.
there's a very strong theme coming through here about addressing risk factors, isn't there? Let's see if we can get a couple more questions answered.
Prevention is much better than treatment here.
Absolutely. I spent this morning an hour and a half waiting for my general practitioner in the waiting room, and we were all over 70. I'm over 70, and it's a sobering thing. It takes guts to get older, but we're very keen to address our risk factors. Carmela, another question, please.
Okay, what are the early warning signs of an impeding stroke, meaning in the weeks or months before a stroke, if any?
That's a great question. Dr. Jubran, do you want to go first?
Like sometimes people will, if there is a closure or a very stenosis, like the size of the artery, instead of it is like this of the neck. This is where the blood going through this artery to the brain. If there is a stenosis there is 70% stenosis, and the patient may have the symptoms of the eye, as we said before, that the black curtain of the eye, and it will come for a few minutes and resolve. And also these patients may experience like weakness on their left side for a few minutes and resolve. And this is the warning symptoms that the patient may have in the last few months. So if any patient has these symptoms, you have to go to the emergency room, to the neurologist, and to check this, because it may be there is a way to prevent the major stroke.
Thank you so much. Dr. Koren, do you want to comment?
Yes, again, very much reflecting on what Dr. Jubran said. The only thing I would actually just like to add to the previous conversation we spoke about as well, in terms of the modifiable risk factors. One specific significant risk factor for strokes, which we haven't addressed enough today, and I think is quite relevant to the Australian audience, is of course alcohol. I think overall, us Australians, all of us drink too much and consume too much alcohol, and they have updated the recommended guidelines in terms of alcohol these days. So we speak about not more than 10 standard drinks per week, not more than 5 alcohol days, at least 2 alcohol-free days per week. And there is one specific thing which I think a lot of us need to be conscious of when we're speaking to our patients, because often people will underreport how much they're drinking. And even if people who struggle to cut down alcohol entirely because of habitual reasons, there are low alcohol or no alcohol substitutes which people can have a look at, and they're available in supermarkets as well.
Is there anyone else who thinks there's something really important we haven't mentioned? Could you take this opportunity, because our time is almost up, because that was so important what Dr. Koren added. Is there anything, Coralie or Lauren or Hamza, that you think, I should mention this? Lauren?
Yes, Julie, I was just going to mention again once more that just in terms of those living guidelines for stroke that we've mentioned several times this evening, just for our audience listening, you can access them as a member of the general public, and they are a great resource that if you are advocating for a family member or loved one, and wanted to check, well, what are the sorts of things my family member should be accessing, should be doing as part of their stroke recovery, that's a great resource that you too can access. So that was one thing. The other thing was just to mention that we also know now as well, supporting people around taking more of a self-management approach to help support their ongoing long-term recovery after stroke. There's a fantastic program initially developed in New Zealand that's now very widely available, got great evidence to show that it helps support people to improve after stroke, called Taking Charge After Stroke, that would recommend people have a further look at that as well.
You just Google Taking Charge After Stroke and up it comes. Coralie English, yes.
Yeah, and adding on to the advocacy piece and people being able to access the guidelines, getting to hospital fast, really very, very important, as we said, and then making sure that your loved one is being treated on a stroke unit. Ask the question, is this a stroke unit? Because we have very good evidence that stroke unit care improves people's recovery and reduces their chance of dying. And all that means is that it's a group of experts. You're getting the multidisciplinary care that you need. So get to hospital and make sure you're treated on a stroke unit.
Dr. Jubran, is there something you think we should mention to emphasize as we close?
As Professor English said, the stroke unit is the main the stroke unit, also the stroke clinic. So the patient came every 6 months to the stroke clinic because the stroke specialist will know what the things that we have to control, to check, to prevent the next stroke and to improve the symptoms.
And what gives you the most hope going forward? Is there an area of clinical innovation or research that gives you a lot of hope, Dr. Jubran?
Yes, of course. Now with the many research extending the time of treatment, to choose the patient that will benefit from the extension of the time, not just to give the medication, the IV thrombolysis within 4.5 hours, to extend it for longer time, according to very specialized imaging, and also for the catheterization to take the clot off. There are many researches when and the best time to do it, and also to include patients that previously they were not included in these treatments.
Okay. And Dr. Koren, is there anything else that gives you hope, an area of research, a clinical innovation?
Yeah, absolutely. I think, especially within the Australian settings, there is a lot of work about trying to integrate artificial intelligence into some of our diagnostic tests. So we are using kind of deep learning models, and I do some of it as my research at the Brain and Mind Center as well, and focusing on training AI algorithms to recognize patterns on MRIs and CTs. And we are trying to already integrate some of those into our healthcare pathways in Australia. So it doesn't matter if you get a stroke in Sydney or in Dubbo or in Darwin or in Alice Springs or Mount Isa. The idea is that when you get the scan, we should be able to recognize if there's stroke there and treat the patients immediately, even if there's no radiologist available.
Look, there are still questions, but our time is up, and I need to thank our panel, and I really do thank you sincerely for the high quality of the information that you've provided, and Dr. Kamela Milka for your careful addressing of the questions and bringing them to us. So thank you to Professor Coralie English, our physiotherapist, to Dr. Lauren Christie, our occupational therapist, Dr. Tal Koren, a neurologist in Australia, and Dr. Hamza Jubran from Jerusalem, the Hadassah Medical Center. We're so happy to have you with us, sir, and we are so grateful that you took the time to be with us. And this is called deaf sign clapping, so I'm just giving you some clapping. And I want to let our audience know that our Stroke Foundation community partner tonight have sent to us a range of resources which will be automatically emailed to you with a feedback sheet. So I'd be so grateful if you could complete the feedback sheet, because they really do read your feedback and try to get the topics that you want. And thank you so much to our audience for sticking with us and asking so many very thoughtful questions. Remember, this webinar has been recorded. You can see the claps coming up that's our audience responding to you. Remember that this has been recorded and will be available on the Wolper Jewish Hospital website as a video recording and also as an audio podcast.